We do have a quorum. I'm just letting, I say that slowly, just letting Dr. O'Keefe and Kirsten Isaacson in. Other folks still trickling in, but we do have a quorum of committee members.
Okay, well, welcome everyone. Good morning. Certainly folks are still joining in. That's wonderful. Happy to see everyone on this sunny day. Hopefully it's sunny where everyone is in Oregon today. It's a beautiful day. Happy St. Patrick's Day. So we have a packed agenda, but a really good agenda, and I'm looking forward to some continued really great discussions among the committee this morning. If we can go to the next slide, please. All right, so the agenda for today, certainly we're going to approve the minutes and the consent agenda. We're also going to, I believe, have at least one public testimony. And then we're going to have a presentation and discussion about the upcoming program changes. Stacy's going to review that and lead us through that. And then we're going to have a presentation and discussion around the OHA's working paper on how other states are incentivizing health equity. And Allison Proud is going to do that. Then we're going to take a break. And then we're going to have a quality strategy overview by Lisa Bowie, OHA's Quality Improvement Director. And then we'll wrap up with some further discussion about how we want to, as a committee, want to think about health equity and performance measures. So if we can move, Joanna, to slide 9, unless there's any questions about the agenda, the consent agenda, or any corrections to the minutes from last meeting.
Dr. Fitzpatrick, can I do a roll call?
Oh, yes, please. I just jumped right in. I am so excited. So yes, please. Thank you.
No worries. So Dr. Stephanie Fitzpatrick.
Present.
Dr. Jorge Ramirez Garcia.
Present. Good morning.
Dr. Manu Chowdhury.
Present. Good morning.
Courtney Wynn Rivera.
Morning, I'm here.
Betty Rivera.
Buenos dias, present.
Andrea Kettlehut.
Present.
Dr. Leona O'Keefe.
Good morning, present.
Morning. And I'll note that committee member Shamiko Montgomery is out of the country today. So we'll review the recording, and I will check in with her before the next meeting as well. I also want to acknowledge your Oregon Health Policy Board liaison, who is Kirsten Isaacson, who is the vice chair of the Oregon Health Policy Board. Kirsten, are you with us?
I am. Good morning.
Good morning. And from OHA, we have myself, Sarah Kleinschmidt, Stacy Schubert, Allison Proud, Andy Parker, Frank Wu, Derek Renke, Katie Howard, and Carly Castaneda. And presenting today will be Stacy Schubert and Allison Proud, both of whom the committee knows, and Lisa Bowie, who is OHA's Quality Improvement Director.
Thank you, Sarah. So I'll go back. Any questions about the consent agenda? Any corrections to be made to the minutes from last month? Looks like no. Okay, so can I get a motion to approve the consent agenda and the February 2023 meeting minutes?
This is Manu. I make a motion to approve the meeting minutes and the consent agenda for today.
Okay, thank you, Manu. Can I get a second?
I'll second.
Okay, Courtney seconds. Okay, Sarah, can you run us through a vote?
Sure. I'll start with Jorge.
I approve.
Stephanie.
Approve.
Manu.
I approve.
Courtney.
Approve.
Buddy.
Abstain.
Andrea.
Approve.
And Leona.
Abstain.
So the motion passes.
Okay, thank you. Thank you very much. So because the sun is shining, I've got all this energy. I'm like 4 minutes ahead of our next agenda item. So I guess first I'll ask if there are any additional, besides the one that I think we know of, public testimonies. Has anyone else requested?
I haven't gotten any additional requests for public testimony.
Okay. Thank you, Allison. So I'll go ahead and read the statement really slowly. And then as the person who's given the public testimony, I believe it's Josh Ballack. Are they already on?
He is, but I want to check and make sure that he doesn't
Perfect.
need a couple more minutes.
Okay, all right. So I'll go ahead and read the statement really slowly. So the Metrics and Scoring Committee welcomes and deeply appreciates public testimony. We thank you for taking the time to provide comments, and we are committed to profound listening and learning. Sometimes we may not respond directly to a comment during the meeting, but after the meeting, the chairs may review and discuss comments with staff to determine appropriate next steps. If there is a misstatement about factual matters such as measure specifications or design, just a reminder to mute yourself if you're not talking. Staff may offer clarifications during the meeting. In any event, the committee will give your comment our full attention and listen with respect. Each presenter is given 2 minutes to share. And in the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help us on time, we'll start a slide with a 2-minute timer for each presenter. We ask that you conclude your comments when the timer is complete. As you start your comment, please state your name and, if appropriate, organization for the record. Okay. And it looks like, all right. So are we okay to start, Sarah? Should we wait another minute or so?
I checked it. So the person who signed up to give testimony is Josh Ballack from AllCare. And I checked and Josh said that he's ready to go now.
Okay. All right, so we can get the timer slide up and then Josh, you have the floor.
Hi, can everybody hear me? Okay.
Yeah.
Hi, I'm Josh Ballack. I'm I work for AllCare Health, and just want to say that the quality metrics program has been one of the most successful parts of the coordinated care model since we started it in 2020 or 2019 or sorry 2013. And you guys have been an essential part of making that happen and throughout the beginning of this process. And I want to kind of like really look back at what you have all gone through and what we have gone through as CCOs and as a committee. I mean, from when the COVID pandemic started and when we were getting this up and trying to keep the metrics program up and running, we've had messed up baseline data, 2 years of report only, slow turnarounds from the OHA because the OHA was overwhelmed around where everything needed to be, provider turnover, increased stress applied to providers, only exacerbating metrics fatigue. The fact that we've been able to maintain and continue doing metrics in this state is, in a word, remarkable and a testament to all of you and your hard work that you've put in. So with that said, with these changes that are being proposed by the Oregon Health Authority to get rid of the Metrics and Scoring Committee, we fundamentally think that is an epic mistake to continue going on. But we too also agree that we should do more to empower consumers and patients in this process. And so what we are suggesting is creating almost a dual process where we keep the Metrics and Scoring Committee and the great work that you guys do. And then we create the committee as proposed by the Oregon Health Authority, but not charge them with creating the metrics, charge them with setting priorities so that this committee then comes in and does the technical work and the vetting necessary to make those metrics work. And then you can ping pong that back to the original committee and have them do the final approval. This way we have both members driving what is being incentivized with our metrics dollars, but this committee can continue to do the hard operational vetting that is necessary. It is a win-win solution, and I strongly recommend all of you to stand up and really fight for protecting what this committee has done. You guys are the lone voice for protecting the patient-provider relationship as it happens in an actual clinical setting. This committee is the committee that brings that perspective and protects that perspective, and has been since the founding of the CCO model. I ask you guys to stand up and protect this committee and stand up and fight. Thank you.
Thank you, Josh. I just want to check in again before we move on if there's anyone else that wants to make a public testimony now.
I haven't received any requests.
Okay. Okay, so move to our next agenda item, which is a presentation by Stacy Schubert, OHA's Health Analytics Director, and she's going to be kind of touching upon a little bit what Josh just spoke on in terms of the program changes and giving us a review on that, and then we're going to have some discussion thereafter. Go ahead, Stacy.
Hold on one moment. I'm trying to get all of my screens set up so I can see where the slides are. Good morning, everybody. My name is Stacy Schubert. And in spite of my German last name, I do have a little bit of Irish in me. So I decided to demonstrate that with my Kelly green sweater. I am the Director of Health Analytics in the Health Policy and Analytics Division of the Oregon Health Authority, and I do use she, her pronouns. Today, we're revisiting the discussion that you all had in December when Sarah presented the legislative concept that OHA put forth, which has been introduced now as Senate Bill 967. So I want to provide a reminder about what's in that bill and give you all space to ask questions of OHA. This bill is designed to complement the equity advancing authorities that were recently granted under Oregon's 2022 to 2027 Oregon Health Plan waiver. I'll specifically be focusing on the portions of the bill that relate to the CCO Quality Incentive Program. It also contains some financial provisions, and I'm not qualified to address those. So if you have questions about that portion, we would round back with you later. Joanna, next slide, please. I know you're all familiar with the health equity definition. It's part of your consent agenda every month, but this foundation, I do want to spend a moment on it. This foundation, this definition is the foundation of OHA's work, and it specifically talks about the redistribution of power. The definition was the primary driver of the authorities that Oregon sought in our recently approved waiver. To move the needle on health equity, OHA needs to use every tool in our toolbox. The CCO Quality Incentive Program could be a powerful tool, but at the moment it isn't designed to eliminate health inequities. Senate Bill 967 will help remedy that through the proposed changes to the program's governance structure. Next slide, please. So I'd like to expand on that. Joanna, next slide, please. Thank you. I'd like to expand on that and give some history about the program. A decade ago, the CCO Quality Incentive Program was designed to reward CCOs for providing exceptional care and continually improving the quality of care for OHP members. Then, as today, the metrics and targets that CCOs must meet to earn the bonus funds are selected through a public committee process, which you're very familiar with. You're part of it right now. There are some things that have changed significantly since the beginning of the program. One is the amount of money that CCOs can earn. In 2013, CCOs earned $47 million. But this June, CCOs are expected to earn $300 million. And to put $300 million into perspective, in our recent state forecast, the budget forecast, everybody was ecstatic to learn that it was $700 million over what it was when the forecast was last done. So $300 million is a lot of money. So while you're certainly aware of decisions you all made last fall to decrease or keep the benchmarks the same between 2022 and 2023 for a third of the metrics. This happened at the same time as the bonus dollars increased by $50 million. Next slide, please. As I mentioned before, the CCO Quality Incentive Program could be a powerful tool, but at the moment it isn't designed to eliminate health inequities. Senate Bill 967 will help remedy that through proposed changes to the program's governance structure. As Sarah discussed with you in January, there are also changes planned that do not rely on legislative action and are related to the program structure. So I'm going to give you a brief reminder about both of these today, and then we'll have time for questions and we can talk about this. Next slide, please. You're pretty familiar with this concept. On the left-hand slide, it shows that currently there are 2 committees which oversee the metric selection and implementation process. The 2 committees are the Health Plan Quality Metrics Committee, HPQMC, and you all. And in the current structure, what you notice is that the communities most impacted by the Oregon Health Plan and health inequities really don't have a large role in decision-making. So with Senate Bill 967, we're looking to right this imbalance and redistribute power so that those most affected by the program actually set the direction for the program. So what we're proposing is a new blended committee called the Health Equity Quality Metrics Committee, or the HEQMC. And on this new committee, the majority of members would be from community and equity experts, and remaining members would be from the health system, such as providers and CCOs. Next slide, please. Starting a new committee is really key to successfully centering the voices and experiences of people whose health is most affected by the Oregon Health Plan. And it allows for relationship building and the natural team development cycle of forming, storming, norming, and performing that you're all familiar with. Under the proposal, the Metrics and Scoring Committee, or you, would continue in parallel with the HEQMC for a year so that there can be knowledge transfer between the 2 committees. And then the Metrics and Scoring Committee would disband in January of 2025. In the first year, the HEQMC will have the space it needs to set the health equity goals for the program before beginning metric and benchmark selection. And there are obviously other activities the committee would undertake, which are covered on the slide. Next slide, please. The other major change that we are undertaking is in the program's structure. And this change doesn't require any legislation, but it's also designed to increase the focus on health equity. We want to create space for upstream measures that will require sustained effort throughout the next waiver period and go beyond typical quality measures. Because it takes a long time to develop these measures and we want CCOs to put sustained effort into them, we have pre-identified 4 upstream measures for this set, which are covered on the next slide. The HEQMC will then set direction for 1 or 2 additional measures to be developed for use during this current waiver period. Once the HEQMC sets that direction, OHA would convene a work group to actually develop that measure in the specifications. And that work group would contain measurement expertise, CCO representatives, and providers to work through the detailed technical specifications that are needed anytime a metric is developed. And that group would also pilot test and refine the measure. The role of the HEQMC in that process would be to provide oversight and feedback, but they would not be in charge of actually developing the metric. And then once the metric is completed, the HEQMC would set the benchmark. The program also will have downstream measures, and these are going to be selected from among the Centers for Medicare and Medicaid Services adult and child core sets. These adult and child core sets are mandatory for all state Medicaid programs. This is a new requirement, and that starts in 2024. So it makes a ton of sense for us to pull all of our CCO quality incentive metrics from that mandatory list of measures. And the downstream measures will be broken out whenever possible by demographic factors such as race and ethnicity, language, disability, and so forth. And the new committee will select downstream measures to incentivize from the measure set. Because they're commonly used measures, all 50 states have to use them in their Medicaid program. This downstream set will actually result in greater measure alignment across the programs than we've been able to achieve thus far with the HPQMC. Next slide, please. This slide shows the measures that are currently incentivized in the upstream category, and they will continue to be incentivized for the duration of the waiver that we're under. And then the HEQMC could identify up to 2 additional metrics, upstream metrics. And then in the distant future, as measures plateau and run their course, the HEQMC would select measures to replace these. So in other words, after this current waiver period. And then I think this is the next slide. This will be the final slide I go over. This just shows the program changes at a very high level. OHA is aware that this is a really big shift. And as such, we're proposing a long runway for the changes to happen. So this slide shows you the timeline for those changes. In measurement year 2024, metrics and scoring committee would be making committee decisions for both upstream and downstream measures. And the source of the downstream measures will continue to be the HPQMC measure set. For measurement year 2025, metrics and scoring committee would continue to make the decisions for downstream measures. Upstream will be held constant. And the source of the measures, the downstream measures, would be the CMS core sets. And then in measurement year 2026, the decision-making would turn over to the HEQMC for both upstream and downstream measures. That, and I do have another slide that shows a more detailed version of the timeline, but I don't necessarily think we need to look at it right now unless there are questions. I also do, one piece of information that I want to make sure that I highlight is we also are very interested and will encourage current and even former metrics and scoring committee members to apply to be members of the new HEQMC. We think that that will be a really important way to ensure that there is some continuity and some provision of that expertise for about metrics specifically. So with that, Joanna, can you go 2 slides, please?
Thank you, Stacy. Really appreciate that. And that was really clear. Questions, comments from the committee?
I have a question. Thanks, Stacy, for going over that. It is helpful to hear it again in more steps to solidify in my brain what's coming. In this committee, there are 3 data experts as part of the committee. And that's not in the new HEQMC committee that I see. So Does that mean that the OHA staff will be considered the data experts moving forward? I saw a head nod.
Sarah, is that something that you want to address?
Sure, I can talk about it. In terms of the data expertise and program expertise, I mean, that's certainly an important piece, and some of that would come from the CCO representatives on there. We also know that there would be health equity professionals who would certainly have lots of data and potentially measurement expertise. And in addition, there may be other folks who would apply and be successful in being appointed to the committee who would also have additional research and data expertise, and hopefully particularly around health equity measurement. So we certainly don't think that that's something that would just come from staff. We think that that is built into the folks who would be appointed to the new committee.
Thanks.
And then, yeah, I'll leave it at that.
And I'm curious, on the OHA team, is there anyone who has worked in a clinic or hospital setting in the past to understand how things work on the ground there?
We're coming off mute. So in terms of our metrics team, there is not, and that's part of why we think it's important and have noted to have providers at the table. And then at OHA, though, we do have providers on staff. So for example, when you all talk about different metrics, we will consult with our providers who are OHA staff. And then we also have the CCO Technical Advisory Group. And while a lot of CCO staff participate in that, there are folks from clinics who participate as well. And that's something that we have now and that would continue under the new structure. Important question, I think.
Thanks.
I have a question. I'm looking at the more detailed timeline, and it talks about recruitment for the HEQMC occurring summer and fall 2023. And I know in the past, in terms of my individual conversations with OHA staff, and I think it's even come up in some of these committee meetings about what's the process for that, and how is that going to be done with an equity lens in terms of the application process, the selection process, who's going to be involved in that, who makes the final decision. So just wonder if you all have any updates on that process now.
Yeah, I can start, but Katie Howard, my colleague who will actually staff the Health Equity Quality Metrics Committee, has been involved with some work that OHA has been doing across all of our committees in thinking about this, because it's important for this as well as other committees. I don't know if you're available to take this, otherwise I can try and jump in.
Sure, I can talk about it. So we are, I've been working on recruitment internally with a team for a year. And so we do have an outline of a recruitment plan. We have, let me bring it up really quick. So I think some like pretty basic equity things that we're looking to do is, for example, the application will be translated into at least 4 other languages. So simplified Chinese, Spanish, Vietnamese, and Russian. And we have started some community outreach. We also have listservs that we are gathering that are standard as part of our protocol. On current applications for committees too, you can check boxes if you're interested in other committees, and we've added a box for CCO Quality Incentive Program committees. That's just a very general catch-all. We will also be doing targeted individual outreach. We're looking at the makeup of the reviewers to make sure that they have health equity expertise, but also community experience. And we also are looking at really having interview process that is trauma informed and really have done a lot of work around how to gauge different types of expertise that haven't traditionally been on this committee, and make sure that we're asking and having that as part of the interview processes. So I think we're really coming at it from a lot of angles. We've also been in communication with Tribal Affairs to make sure that they are up to date on where we are with the legislative process and just our committees in general, because we recognize that we haven't had a tribal representative on a CCO quality incentive program, and that's a really important thing for us to remedy in the very near future.
Thank you, Katie. Can I ask just really quickly, who are the reviewers?
They have not been identified.
Okay, how will they be identified?
We will be working with, I'm hoping that we'll be working with OEI to identify some of them. So the Equity and Inclusion Division. We also have staff that are looking into it, but we have not identified who those people will be yet.
Okay, thank you, Katie. Go ahead, Manu.
Thank you. So I have a few comments, but the first one that I'd like to make is around this idea of health equity. And I know this health equity is a buzzword, and we have defined it, over the last few years, and we've really started to line up a lot of decisions against this health equity definition. Like many of us here, we have a lot of different professional backgrounds that we bring to the table, and those impressions guide, whether personal or professional, as we carry forward. And one of them that's been very big for me is something called the quadruple aim. And so that everyone knows the triple aim, the quadruple aim integrates also the care team as a part of the process to ensure that the care team remains healthy as well, when we really think about taking care of patients and achieving real population health. And then, of course, definitively with the health equity lens. And the HEQMC, as proposed by Senate Bill 967 in one of the previous slides, supports this idea that the majority of individuals on the new evolved metrics and scoring committee will be community members, which is rightfully so when we think of power redistribution. What I would like the committee to discuss is potentially keeping things at 50-50, where we have provider voices and those that are boots on the ground delivering on the measures be best suited to also be present in order to inform for future benchmarks and targets moving forward. And then the other 50% of the committee being supported by this power redistribution, by bringing community members, those that like, for example, tribal representation, or someone with special needs, or IDD or something like that, also being the other part as well. So I'm not sure how far down we are in this process. I realize my video is cutting in and out again, so I'm going to go off video. I do have a few other comments, but I was wondering if we can kind of discuss this first before we move to those.
Thanks, Manu. Do folks have comments to what he's asking about in terms of this, the idea of maybe having it 50-50 for the Health Equity Quality Metrics Committee versus a majority of community and equity expert members?
I support what Manu is saying. Again, really supporting shifting power to the community, and particularly allowing them to set direction or priority of what the needs are. But absolutely agree that the people who are in those one-on-one relationships with the community members also need to be taken care of. And I was trying to figure out, well, how could we do that? We can't, if you make the table too big, you're not going to make much forward movement. So rather than adding more members, I think that makes sense to make it 50-50, because right now there's 5 members who are providers, CCOs, and previously you had mentioned also one of those 5 would be from behavioral health, which makes sense. And I know CCOs to some degree should represent providers, but you know, they're often not the ones that are in clinic or in hospital doing the work. And, you know, I can't come in here and say, well, I spend every day with Black and brown folks, so I can represent them fully. I don't think we can say CCOs can fully represent providers all the time either. So I think you need to have the providers in there. And with the 5 representing CCOs, providers, and behavioral health, I think that voice is being minimized. And I don't think we need to minimize that in order to also increase the voice of our community members. So I like Manu's suggestion. I think it's reasonable to make that split 50-50 so we don't get so many voices that you can't make progress, but that all of those voices are still able to be heard.
Thanks, Leona. Stacy, I saw your hand up. Did you want to?
Yeah, I did want to address this. OHA really was very intentional with our proposal. And that is because we have found through support of committees, not just our staff here, but across all of the committees of the OHPB, that community members who sit on committees really do need a little bit more flexibility, and they may not be able to attend every meeting. They don't have a vested interest in the committee in the same way that folks who are paid as part of their job do, or as part of their job are paid to be sitting at the committee. So because of that, we felt that it was really important to have a higher proportion of community members versus the health system members to ensure that we truly are redistributing power according to OHA's definition of health equity.
And this has already been proposed to the legislature, is that correct? And so when would it, so it's too late to change anything, I think, in this round, is that accurate? Or
bills have amendments all the time. So it's, you know, it's not necessarily too late for changes.
Can you share that process at this point and when it would be voted on in its final form?
We don't have a crystal ball to be able to know that, and we're not in charge of that. What I do know is that the bill was introduced on the 15th, so 2 days ago, and it is scheduled for a work session on the 22nd, which is next Wednesday.
I did want to make a note that I do agree, sorry to jump in front, Gladys. I do want to make a note that I do agree with the power redistribution. Fundamentally, I think it's the right thing to do. My only concern is the balance as we carry forward, because of any type of measure is going to have an impact on the healthcare community. It's going to have an impact on the members who receive that care as well. And so when we think of an overarching, in a sense, steering committee like this, it's better if we walk hand in hand together than to feel as though there is a power shift too far in one direction than the idea of what can be brought forward.
Gladys, go ahead.
Yeah, Stacy, I wanted to ask a specific question when you were talking about community member selection. Are members of this new committee who are consumers, potentially Medicaid consumers, are they going to be paid during the time that they are working in this committee? Okay, it looks like they are. So I have just a question over, oh, go for it. It sounds like you want to.
Can I just say, we do, and we hope that they will be able to be paid. There is currently a law on the books that is very challenging to understand and to actually implement. But today, if somebody, they have to meet certain criteria. So I believe it's that they have to have an adjusted gross income of less than $50,000 and basically not be paid by their employer to, to sit on a committee. They're paid the same as legislators. I believe it says legislators are paid, which currently is $157 a day. So we don't know how that would change because there are a number of bills in the session right now to try to fix that really flawed law. But it is absolutely our intention to pay community members who sit on the committee.
Perfect. Thank you. I have two more questions for you. So when I'm looking at slide 15, it talks about majority, community, and equity experts. And I think Katie Howard jumped on and gave us an overview of what the process is going to look like. I hear what my peers are saying as ensuring that there are providers at the table to really talk about how the work is happening at a clinic level. So equity experts, could that be an additional provider that meets that additional criteria? Like, help me understand the selection of those two. And then I have one follow-up question, an additional follow-up question.
Does someone from the team want to take that one, or do you want me to take it?
You can take it.
The way that I have been thinking about this is that the community seats, the really delineating factor or the distinguishing factor between seats that represent community versus seats that represent health system is that the seats that represent community would not have an affiliation with or benefit from in a relationship with a health system.
Thank you for that. My final question around this is, for example, community advisory councils, which are subcommittees of the CCOs, they already include consumer members. Is that a group that folks are thinking of coordinating with and communicating with around this change? Because it does take some time to learn the language, right? The systems were intended as created. That can be really challenging, but you already have individuals that may be on these committees for a year or two, maybe even longer, and have some general understanding and awareness and have collaborated with, clinical advisory panels. So can you help me understand that piece?
Sure, I can take this one. I have reached out to Tom Cogswell, so he is aware of the legislation, and we've talked about reaching out to the CACs, and that would be part of the recruitment process. Also, we recently were very lucky to hire Susan Cross onto our team, and she has done a lot of work with CACs, especially in the Gorge region. So we are planning to really tap into that network because we think it's important that they always know what's going on with the CCO Quality Incentive Program, but I think you're right that there is expertise there. I think one difference though between the CACs and this is that this would not be advisory. So I think it's also a way to take that knowledge and help build it into the process. So thanks for that question.
Thank you. That's exciting to hear that Suzanne's a part of this work, representing the Gorge, where we have a really good working relationship with our CACs and our CAPs and whatnot. And I think that that's brought a lot of success to access overall within the Gorge. Thank you.
Jorge?
I think it's important to not lose sight that there is a lot of alignment and commitment and agreement on being able to increase the health equity component of our program. And that what I'm hearing is that there is a lot of agreement on that principle across stakeholders. These details are very critical and important, nothing to undermine that. But I would like to emphasize and underscore that. I would also like to state that and remind myself us that we're all members of the community, whether we work for a CCO or we're data experts, or we're all members of the community. So I think that we're trying to get at different roles that we play, and we have many different hats. And I think that there is a lot of opportunity to discern what is the right, or what is an optimal mix for a committee or set of committees that can move this work forward. Let us keep that in mind as we define what a community member is, for example, and let's not lose sight of the level of readiness that we bring to the table to absorb this complex set of issues in measurement, whether one is quote unquote a community member or data expert. I think that there is a lot to be done in maximizing the opportunity for that committee to be, or set of committees to be functional. If the level of readiness is optimized, readiness in background information, and being able to commit to attend every meeting, unless under grave circumstances, which will happen to us. Thank you.
Thank you, Jorge. Really great comments. And I'll just say really quickly, and I know Manu has another question. To the extent possible, maybe I'm just volunteering myself to Katie Howard and Stacy and other, lean on us too, as you all are thinking about this process, selecting reviewers, selecting members. Jorge makes a really good point. We are also part of the community. We're also equity experts as well. And so if we could at all be helpful in terms of thinking through the criteria for these members, please let us know. Manu, go ahead. We've got about 2 or 3 more minutes left on this topic here. Go ahead.
Great, thank you very much. First off, Jorge, really nice comment on we're all on the same team and we're all one community. That far, in my opinion, outweighs my comment around the quadruple aim. So really nice for calling that out. The question that I have is, and then I have a follow-up. I have 2 questions. First one is, will the financial incentives change as we move forward? I know you mentioned right now, I know, Stacy, this question is directed for you. I know you had mentioned right now, we're looking at $300 million in incentive payouts over the next few years. Is that expected to go up or go down or stay the same?
So part of the reason that it's at this historic level right now is because during the public health emergency, that renewals for Medicaid, people essentially were not kicked off of Medicaid except for a couple of very unlikely reasons like death or leaving the state. So that means that the Medicaid rolls have continued to grow bigger and bigger and bigger. And the payout is based on the number of members that are in a CCO. And it's a proportion of the per member. It's calculated on a proportion of the per member per month capitation payment that CCOs get. And currently, that is 4.25%. So when you change one part of that equation, which is the number of members, and the number of members is just going up, that's why we've reached 300 million. We do know that the public health emergency is ending, And every single one of the 1.4 million Medicaid members does need to undergo a process to determine whether they stay on Medicaid. OHA is anticipating potentially about 300,000 people to no longer be on Medicaid. So that will reduce the payout below what it is today for next year. The 4.25%, that isn't necessarily set in stone anywhere. So that could be lower or higher.
Sorry. Okay, great. Thank you very much for sharing that in really nice detail. I really appreciate that. Very thoughtful, methodical response. One of the last question that I have is that earlier on in your presentation, you noted that that within the Medicaid waiver, there were also financial provisions. And I was wondering if maybe at a subsequent follow-up meeting, if that can be shared, just to help kind of allow us an opportunity to look at things from a goal perspective to ensure that whatever decisions we're making are appropriately aligned with what we do. Thank you.
Yeah, we can talk about that. I mean, I wish I understood exactly what it is that is in the other part of the bill, but I actually don't think it would have that much effect on your thoughts here today. It essentially gives OHA authority to make non-risk payments. I think I'm getting that right. Chelsea Guest would probably be horrified by what I just said, but essentially I think that's what it does. But if you're interested in having a greater level of detail on those provisions in the bill, given I mean, it will depend, of course, where this bill is in the legislative process by your next meeting, whether we need to still talk about this or not. But we could have her back or have her come to the meeting and spend a few minutes with you.
Okay, great. I would really appreciate it. Thank you. Sorry, Dr. Fitz.
No worries, Manu. Thank you so much, Stacy, again for that presentation. And it sounds like this might be a little bit of an ongoing discussion, even though I think things are kind of written in stone, but certainly in terms of the process and the rollout of this, I think certainly we can still make sure we incorporate some time into future meetings for discussing. I want to now move over to our next agenda item and give Allison Proud, poor thing, who's been waiting since last month to present on this. And some of you all are already aware, I've heard about this working paper that OHA team members have been working on in terms of understanding what other states are doing to incentivize health equity. And so Allison's going to give a nice presentation, providing an overview of that, and then we'll have some discussion thereafter. Go ahead, Allison.
Thank you, Dr. Fitzpatrick. So I think most of you know who I am, but for the sake of the public record, I'll introduce myself. So my name is Allison Proud. I'm part of the Quality Metrics Surveys and Evaluations team here at OHA. I work with Sarah to staff this committee, and then I work more generally on the incentive program overall as well. So at our previous meetings and this meeting as well, we've been talking a lot about the ways we can implement a more equity-focused approach to the incentive program. And an important part of that work is to see what other states are doing to incentivize improvements among their Medicaid populations. So with the help and support of my colleagues, I have been analyzing program documentation and contracts in other states to understand how this work is being done. And this information has all been compiled into the working paper, which was included as part of your materials for today's meeting. Those of you that have been on the committee for at least a year or so may recognize some of this presentation. We initially presented on this topic to the committee last April. That presentation was a very high-level introduction to the research, and today's presentation is going to serve as more of a reorientation to the material, while also going more in depth into the details of other states' incentive program components, and then how that work can inform our work here in Oregon. Next slide, please. So here's an agenda for today's presentation. We're going to start with a quick user guide to the working paper, and I'll get into the context of the work, why it's important, and what we can learn from other states. I'll also acknowledge the limitations of this research. I'll then give you a quick overview of the types of information we were looking for from each state and how that information is organized in the working paper. And then we'll have a summary of the current findings, including examples from other states. And then there's some time held at the end to talk about next steps and allow for questions and discussion. You know, just as a little spoiler, we're really looking for the committee's input for the next steps, as this research is ultimately here to help guide your decisions. Next slide, please. So we consider this paper to be our field notes, a sort of evolving notebook of examples from other states. It is not a roadmap for our work here in Oregon. The working paper compiles information on how 7 other states incentivize health equity improvements within their Medicaid populations. There may be other states that incentivize equity. This is not meant to be an exhaustive list. We are hoping that the working paper spurs conversations and additional questions. And as we learn more, we'll be adding and updating information to the working paper, and our interpretations may certainly evolve as this work moves forward. Next slide, please. So I wanted to take a minute here to really emphasize why we are taking the time to collect and compile all of this information. So as you all know, here in Oregon, we are aiming to center health equity in all of the work that we do. And with that in mind, it's useful to understand where other states are in this process as well. So, we're looking to see, what methods are the other states trying? How did they decide on those methods? What's working and what isn't working? We can use what we learn from these other states to guide our conversations and choices as we continue to work towards achieving health equity in Oregon. Next slide, please. So with all of that said, there are limitations to this research that needs to be acknowledged up front. So first of all, the paper does not reflect direct input from affected communities, and we know to improve equity, it's vital to create a continual feedback loop to understand the community's outcomes, whether measures are appropriately being used, and if improvements are being made. Next, the paper collects examples that are being tried in other states, but we know that all approaches have both costs and benefits. And just as an example, and we'll talk about this more later in the presentation, some states use the white non-Hispanic population as a reference point to set benchmarks for reducing disparities. This benchmark approach doesn't recognize that the white non-Hispanic Medicaid members may not be getting high quality care. And additionally, the very practice of defining a reference group may suggest that other groups are non-normative and may also promote assimilation and acculturation. Also, the working paper contains only publicly available information. Varying levels of detail are available across states. There may be more details on equity incentive programs that we don't have access to because they're not included in public reports and sources. And we'll be continuing to update the paper as more information becomes available. Also, Oregon CCOs are not necessarily analogous to the Medicaid Managed Care Organizations, also known as MCOs in other states. So caution should be taken when making comparisons between these two types of organizations. And finally, Oregon has landmark Real D legislation, and there may be a difference in how race, ethnicity, and other demographic groups are defined from state to state. Next slide, please. So this is an overview of how the paper is structured. We chose to focus on the 7 states listed here for our research. There may be other states that incentivize equity, and we're hoping to add more states to this paper in the future. So when researching the states, we looked for 5 main types of information. So first, we looked into the types of methods used to measure health equity improvements. We also looked for reporting requirements, so which measures are required, which categories they stratify by, if any, and how they decided their stratification groupings. We also looked at benchmarking, so we wanted to see if the states set benchmarks for their stratified measures, and if so, how they chose those benchmarks, and what is the benchmark source. We also wanted to see if the states offered incentives for improvements in health equity, and are those incentives given for achievements in structural equity milestones or for demonstrated quantitative improvements in the reduction of disparity gaps. We also looked into how the states defined a disparity gap and how is a significant reduction in their disparity gaps calculated. And then finally, we looked into funding. So if the states provided incentives for equity improvements, we were looking to see how they funded those incentives. Detailed findings for each state can be found in the working paper, but for today's presentation, we're going to go through and summarize the key findings. Next slide, please. So I'm going to jump into the key findings here. You'll notice that on each of the key findings slides that we've included a call out box that lists some considerations for us to keep in mind when thinking about how these findings apply to our work in Oregon. All of these considerations are restated at the end of the presentation to help aid in your discussion. So looking into the findings, we found that most states use multiple methods to address disparities and measure improvements in health equity. And these methods can be categorized broadly as either qualitative or quantitative. So qualitative methods require the completion of a health equity quality improvement milestone. So these milestones are activities that are specifically designated by the state as process or structural measures that contribute to the overall improvement of health equity. So some of the qualitative methods that we found in other states included things like staff and provider training requirements and meaningful community engagement. On the other hand, quantitative methods aim to show a measurable improvement in achieving health equity for one or more populations. In practice, this means reporting stratified quality measures and comparing the performance of a population of interest to a benchmark. The goal is to show improvement over time by shrinking the gap between the population of interest and the benchmark. In the next couple of slides, I'm going to give more detail into how the states using quantitative methods are doing things such as defining a disparity, picking a benchmark, and measuring improvements. But before we dive into that, I do want to clarify that while all of the states we researched used one or more methods, they are not necessarily incentivized. A state may, for example, use both a qualitative and a quantitative method, but only provide an incentive for the completion of one of those components. And I'll talk more about the incentivized components later in the presentation. Next slide, please. So every state that we reviewed requires their Medicaid plans to report a set of quality measures stratified by race and ethnicity. And the measures that comprise these measure sets vary across the states in both number of measures and measure source. So measures commonly come from national sources such as HEDIS, the CMS core set, and the CAHPS Consumer Assessment Survey. Some states, like Oregon, also use homegrown state-specific measures. Overall, states have focused their current health equity initiatives on reducing disparities first among racial and ethnic groups. Only a few states require additional stratification, such as by geography, language, disability, gender, sex, and age. Next slide, please. So when looking at benchmarks, we found that most states use the national average, the statewide average, or the white non-Hispanic performance rate to set benchmarks. States will use different benchmarks for some measures depending on the measure source. So for example, a state may use national Medicaid percentiles to set benchmarks for a HEDIS measure, and then they may also use state level performance rates to set benchmarks for a state specific measure, just like we do here in Oregon. So as I said before, when discussing limitations, it's important to note that there are caveats when using a population group as a reference or a benchmark. Identifying a certain group's performance as the ideal outcome and then expecting other groups to achieve this performance ignores the historical and structural limitations and barriers that, as we all know, continue to play a role in our healthcare system. And this is just something to keep in mind as we consider the possibility of setting benchmarks for race and ethnicity groups within our incentive measures in Oregon. I do also want to call out here that these benchmarks are not necessarily tied to the receipt of an incentive payment. So in some instances, the benchmark is for comparison only to highlight population disparities. Next slide, please. So we found through our research that some states provide incentives for successful completion of the qualitative and quantitative methods that I talked about previously. And just to refresh your memory from a few slides back, a qualitative method requires the completion of a health equity quality improvement milestone. So one example we found of this can be seen in Louisiana, where managed care organizations can earn bonus funds by completing and reporting on equity-related activities, such as meaningful community engagement and staff and provider training requirements. Another example of this we found in Minnesota. So Minnesota has an incentive program similar to ours, where incentives can be earned by achieving benchmarks on a set of quality measures. And just this year, Minnesota added the health equity stakeholder and community engagement measure to their measure set. To meet this measure, the managed care organizations must report on at least 4 health equity community engagement activities. For quantitative methods, we know that the aim is to show measurable improvement in achieving health equity through the reduction of disparity gaps. An example of this type of method can be seen in North Carolina. North Carolina is planning to implement an incentive program later this year that will provide bonus funds for demonstrating a 10% relative improvement in the performance of priority populations compared to the overall population. Michigan also has a similar program where managed care organizations can earn bonus funds by displaying statistically significant improvements in reducing disparity gaps, using the white population as a reference group for a set of HEDIS measures. We found that most states utilize one or more qualitative or quantitative program components. Something else that we noted was that many states choose to incentivize improvements for only a subset of their measures or for only some race and ethnicity groups. States that use this method noted that they were choosing to focus on the areas of health and the populations that have the largest noted disparities. So an example of this can be seen in Pennsylvania. Pennsylvania requires reporting on a large set of quality measures stratified by race and ethnicity, but the incentives are only tied to performance improvements among Black members on 2 different HEDIS measures. Next slide, please. So moving on to funding, we found that of the states that provide financial incentives for improvements in health equity, most withhold a percentage of their capitation rate to fund the incentives. This percentage ranges in the states that we researched from 1%, which is in Michigan, to 8%, which is in Minnesota. Next slide, please. So as I said earlier, we're gathering this information to help guide and inform your discussions regarding health equity improvements here in Oregon. I've summarized the considerations for Oregon listed on the previous slides here to help aid in your discussion. In addition to the considerations listed on this slide, we would like your input on what we do next with the working paper. So is there anything you would like staff to look into further? In what ways can we use this information gathered here in our work over the next few months? All of these questions are really here to help jumpstart your conversation, and we're really eager to hear your thoughts and feedback. So at this point, I'd like to turn it back over to the committee for questions and discussion.
Thank you again, Allison. This is really excellent work, and really helpful for us to have at our fingertips. I have one question in terms of the future, in terms of next steps, or maybe not a question, a suggestion. What would be helpful is if any of these states are publishing the effectiveness of these approaches. It seems to me like there's a lot of people like, let's try this, let's try that, but there's no like, okay, and then what happened? Did it help or did it hurt? And that certainly would guide, I think, our work. I mean, we might also have to just kind of step out and be brave too and say, let's try it. But we certainly don't want to re-traumatize the community either. So, to the extent that there's any follow-up and conclusions, that would be helpful. Other committee members' thoughts or any answers to some of these questions that are here on the screen right now? Jorge?
Yeah, an opening comment is that this is excellent work. I want to echo that as well. This is really comprehensive and in-depth, and not to miss that, what the quality of this report and summary. Thank you very much. We do live in the United States of America, and each state has its own challenges and purviews and a set of considerations to provide their own population health strategies. So we do want to caution that the transportability to our state is not necessarily a one-on-one relation of sorts. But there is a lot to learn here. And this is grounded in reality of applying a CMS incentive program. So there is a lot that we can benefit from. Thank you.
Thanks, Andrea.
Thanks, Allison, for presenting and sharing that. I think, Stephanie, I would kind of align with what you just asked. I would love to hear more. You know, Minnesota over the year has done a really good job in this space. I would love to hear a little bit more about how Minnesota's kind of process improvement, attestation work, what that really yielded in the improvement of health equity, and kind of what some of those different strategies were that they used in this space.
Thanks, Manu.
I really would like to start with echoing your comment that you made. I think it's very critical that we identify what has driven better health outcomes and then look towards integrating that in our own, so that we're really not starting from step one, right? We can try to start from step 4 if we can, then we should, because re-traumatizing or traumatizing our community for the sake of starting something is it's more important. You know, when we think of equity, we don't want to re-traumatize. We really want to start, you know, as high enough as we can. And then the second comment that I want to make that I brought up at the last meeting is that the D of disability in Real D, the current working knowledge of it is grounded in information and publications from 2005 to 2007. And what we understand today of disabilities are far more than just what is being currently asked. And so, you know, like what I brought up earlier around individuals with IDD, those are other types of disabilities that do exist beyond the ones that we're currently asking about. And so we do need to make the D of Real D as strong as our questions. And when we think of health equity changes and strategies that we already have with race and ethnicity, and even now with language, but really where does D lie, and how exactly are we going to improve the health of our community, and particularly those who are considered disabled. Thank you.
Thank you, Manu. Go ahead, Gladys. Yeah. You're still muted, Gladys.
There we go. Can you hear me now?
Yep.
Okay, so this is like a comment and a question. So hear me out. The last question on here, what other funding options are there for equity work? I want to bring up a barrier because I think this is something that, similar to Manu's question around finances, this is something that we need to better understand and ensure that we are being equitable around reimbursement. So let's talk about the HOP expansion really quick. This is allowing expanded Medicaid access to individuals that do not have legal status, right? Everyone on this call wants to provide additional access to community members that don't have it. At the same time, those clinics are taking on more patients, and they're also not being reimbursed at the same rate. So it is important for us to understand, if we're going to add even more patients to a clinical panel, but they're not being reimbursed at the same rate, like how is that going to be sustainable for those organizations that really are doing more work because they are adding more patients to the panels overall? And echo the question around, like, we need to have, you know, what were the outcomes of all this work that was achieved or implemented so that we don't start reinvent the wheel again.
Thanks, Gladys. Go ahead, Courtney.
Thanks, Stephanie. So thanks so much, Allison, for presenting on this. This was incredibly helpful and really cool to see the differences between some of the other states that are incentivizing the quantitative versus qualitative. I did kind of want to mention that I know that I suggested the qualitative piece last meeting, and I'm not necessarily taking that back, but I do want to recognize that there is a lot of qualitative work happening on these topics throughout a lot of other deliverables that the CCOs work on. For example, the health equity plan. So just kind of keeping that in mind and making sure that we're aligning and not duplicating efforts if we do choose to go down that path for incentivizing health equity. And then I think for the quantitative piece, I was curious for some follow-up questions, if there's any way we could look into how some of the other states selected the subset of measures to incentivize for the quantitative piece. I see that one of your questions is related to pros and cons of incentivizing improvements for only a subset of measures. So I don't know if I have a great answer to your question, but I think it would be helpful to know how those states did go about their selection process for the quantitative measures. Because I do think it is interesting to start with a subset that maybe have greater disparities. So kind of curious if that's the same process and train of thought that they utilized for that. Oh, and then one last thing too on the REAL-D data effects. I do think, we have a lot of REAL-D data missing currently, but a lot of really awesome work that's happening to kind of bridge that gap and get more REAL-D data, which is really exciting. So I think once we have that, we'll have a better ability to, stratify by REAL-D data components. One question or concern I had was related to the clinical measures specifically. So the EHR-based measures, I know that's not something currently the OHA is able to calculate because we don't provide, we being the CCOs don't provide member level data. So I'm curious if there's any thoughts around that piece.
Courtney, can I ask on that last question, do you mean with the EHR measures, like ways around how you as a committee might think about that in your framework because we're not able to stratify those?
Yeah, like how would you go about even adding some sort of REAL-D stratification component or incentive to those measures if we don't currently have that data available? And maybe that's requiring the CCOs to report on member level data. I'm not sure.
I don't have a great answer. Some of it is following the data and some of it is conversations that you all might have about kind of what you were talking about at the previous meeting, like having, if you don't stratify by race and ethnicity in a quantitative piece, is there something structural that could be looked at?
Allison, can you answer Courtney's question about how some of the states did decide on which measures to do health equity benchmarking on?
Yeah, in general, the states that chose subsets of populations or measures aimed to go for the measures or the subsets of populations that displayed the largest disparities. Though we can certainly look to see if there was more information presented other than that, or if there's going to be future information that comes out from those states regarding how they chose the populations or measures. We can add that into the next update of the working paper.
Thanks, Allison. That would be helpful. I know, we have the challenge pool measures, which is another way for us to kind of, as a committee, put greater emphasis around certain measures. So I wasn't sure if any of the kind of aspects that we use in our decision making for challenge pool measure selection is taken into consideration with these other states. So that would be helpful.
Mm-hmm. Yeah, that makes me think about this last question and going back to kind of Gladys's point too, in terms of what other funding options are there for equity work. I think what stuck out to me when I was looking through the working paper is that they were taking withheld funds, which I assume was a separate pot of money from the incentive pot. I could have been interpreting that wrong, but it just seemed like it was like, we're going to take this money over here and that's just going to be the health equity stuff. And then everything else is our usual program. And I just to be honest, I get really disturbed when we start to view health equity as this thing over here we got to deal with, as opposed to it's part of the whole picture. Standard of care should actually be providing equitable care. That should be the standard across the board. And so when thinking about funding options, I mean, certainly if we're thinking about kind of a glide path or a ramp up, and according in terms of the challenge pool and using those dollars, right, to, you know, start to see kind of how it goes at a smaller scale and test from there. But, you know, throughout, you know, all the metric setting and all the benchmarking process should all be done with an equity lens, and it should all just be part of the program and the package all together is how I see it. The other thing is, and I think we've discussed this before as a committee, you know, in terms of how do you define disparities? Do you define it based off you're comparing to this reference group, which it seems like for some states are using white non-Hispanics, or do you compare to kind of the state average? I certainly have personal issues with comparing to white non-Hispanics as the reference group for various reasons. And Allison, I think you spoke to those. I sometimes like to, you know, even my own research, I'm thinking about within group, you know, where did they start and where are they now? And is the program actually helping them to improve along the lines? And certainly you can look across the board, across all the groups and see, you know, I'm thinking about the dashboard and the different graphs that we can see clearly, you know, Pacific Islanders, Black, African American, Hispanic, Latino at the bottom for some of these metrics here. But sometimes I just think about the group being their own control and really, you know, honing in on that as opposed to always kind of comparing to some other mainstream group or the dominant culture or whatever, or even the state, because even the state is somewhat flawed when you average across and you've got people at different places that certainly could impact the mean. So just some thoughts that I had as I read the paper. Manu?
So I have, you know, I'm reading the second bullet from the bottom. What are the pros and cons of incentivizing improvements for only a subset of populations and or measures? And you know, as I think about that and reflect on that, I personally agree with that for upstream measures. And then when I think of downstream members or downstream measures, you know, when I think from a dental perspective, you know, anything we can do to increase utilization, like around preventive care or ensuring that someone who's diabetic has an oral health exam, I think that is an acceptable kind of incentivizing for a subset. But when I think of something that's a little bit more controversial, like immunizations, for example, then I know that from my experiences, different ethnic groups are more skewed away from vaccinations as opposed to not. And then I get a little bit kind of concerned of, you know, are we driving, you know, from a public health perspective and hat, are we driving for doctors to not, you know, to provide different care to different people? And I'm a little bit concerned about kind of walking through what that means to how healthcare is delivered and when and where should that line be drawn.
Any thoughts or comments on what Manu just said? Yeah, and it's, I mean, I think that goes back to, you know, I certainly that point was made during this meeting and even last meeting, the importance of the community input too, right? And so, you know, we're not going to do this work in a vacuum. The Health Equity Quality Metrics Committee can't do the work, even with community members, can't do the work in a vacuum, to start to understand the implications of what we're proposing and what we're thinking about in terms of the benchmarking. So you're exactly right that there's certain metrics that certainly have either controversy around it or certain cultural beliefs and stances that need to be taken into account before we say we're going to incentivize CCOs on getting this number when it actually could be causing more harm or division or disparities. So, yeah. It looked like maybe Katie can share a couple of more ideas to or answers to Courtney's question about EHR-based measures and what the CMS wants, what CMS wants.
Yeah, so thanks. I do a couple things on the team. So one thing that I also do is I oversee the EHR metrics for the team. And I have been following what CMS has really been asking for. So this fall, they put out a notice of proposed rulemaking, and they're very much moving in the direction of stratifying all measures, and that by race and ethnicity. And they're moving in that direction, both for administrative metrics as well as electronic health records. So we can see CMS is really moving in this direction, especially through the federal government's FHIR standards. So those are healthcare interoperability standards, and we see them adding race and ethnicity there. At the state level, we're really thinking about the future and how do we get those data those EHR data at the member level. And so we're exploring what would be the framework to do that and hiring a contract to centralize those data so that they can be lined up at the member level and joined to our RealD and SOGI information. So the state is very much moving in that direction. And for me, the EHR metrics are often the clinical outcome measures, and it's very important that we continue to move in that direction of being able to stratify them by RealD and SOGI.
Thanks, Katie.
Thanks, Katie. That's helpful. Do you know how far off that would be, just out of curiosity?
I'd say that's like 4 to 5 years.
Okay.
Yes.
That sounds about right. Thanks.
Manu, I saw your hand come back up.
Yeah, thank you. So, you know, one of the other committees that I serve on is the Health IT Oversight Council. I've been a part of that, part of that group since 2021, and I'm also co-chair of the Health Information Exchange Work Group. And on one hand, as we lean more heavily on EHR or electronic health records, the fundamental reality is that not all electronic health records are made equally. And only if they're certified do they have the ability for the FHIR API or any other additional APIs. And then the other reason why I bring this up is that there are no dental providers outside of those in a PCPH model like a community health center that utilize an electronic health record. So as we start shaping and determining and deciding, you know, how can we take measurement data from electronic health records, we need to understand that we are deliberately only looking at physical health provider data. We're not looking at behavioral health data or access within behavioral health spheres or access within dental spheres as well. And so, you know, these things are obviously being discussed on HITALK and on the HIA work group, but that needs to be solved as well as we start applying that towards future measures with this committee. Thank you.
Thanks, Manu. That's a good point. So we're just about at break time. And keep in mind, I think hopefully we're going to have about 20 or 30 minutes left after our next presentation. So we'll have further time to discuss and I know some people have been percolating as we've been going through some of these presentations. So we'll have some further time later on. But we're going to take a 15-minute break now, if everyone can be back by 10:45. Okay, I have 10:45. So welcome back. And now we're going to have a presentation on the quality strategy, or an overview of the quality strategy from Lisa Bowie, who is OHA's Quality Improvement Director. I'll turn it over to you, Lisa.
Good morning. Hello, I'm Lisa Bowie. I go by she, her, hers pronouns. I'm wearing dark black rimmed glasses, have dark hair, and have a picture of the Silver Falls behind me. So I will, who am I? I'll just say advance slide to somebody and magic will happen behind me, I'm sure. So today's agenda, our collective conversations will cover a little bit high level of CMS. They've now come out with some new strategic direction. So I think it's good to have an overview of what we, the state, are being told. So then you can know where the direction's going for that alignment. And then I'll go into Oregon's Medicaid quality strategy and overview, then connect that to obviously our OHA strategic goal, which we've all been talking about today, then link it back to your direct work here, and then what's coming. Next slide, please. Triple aim framework, and thank you, Manu, for bringing that back up to the quadruple aim. So we all know better care, better health, lower cost, and then yes, there is the quadruple side. I think someone asked earlier about who at the agency has that on the ground work, and yes, I've been at the agency for a little over 7 years now, but I did work at a federally qualified health center. So one of the reasons I came to the state was honestly one of those pet peeves of this is how it impacts the members and this is how it impacts the providers. And many have heard me say, I really don't like having 9 different diabetes poor control measures because, you know, I was measuring it 9 different ways and I really, really didn't like that. So I came to the state to kind of stop that. So some of that on the ground practical knowledge, yes, I hear y'all. Let's go to next slide, please. So CMS has come out with a 2022 strategic plan and a national quality strategy. I won't read these slides to you, but I just really wanted to give them to you as a reference. If you click the hyperlink, the blue underlined text, it goes to some of the information that CMS is putting out. They are, again, don't have, they're building up their websites and a lot of details, but if you do go to the CMS Quality Conference in May, I didn't give you that links, but maybe someone from the OHA side can drop some of that links into the chat string. If you're on my QHOC, the Quality Health Outcomes Committee meeting, I've been plugging that through those distribution lists. You'll be hearing more about that coming up. Next slide, please. These again are their strategy goals. If you follow the national, basically they came out with one in 2010 and they have been basically refreshed it now a decade later. They did kind of an interim refresh in 2016, but they really have revamped it. They are recognizing, to Manu's point, the workforce and the kind of fatigue, but they have also recognized what we've all learned from post-pandemic and you know, social justice, and they've recognized the health equity side. So you'll very much see the presence of health equity and workforce in the CMS National Quality Strategy goals, very much so, and you'll see the downstream impacts of that in the metric side. Next slide. Now here's where I really kind of want to focus a bit of our attention on, and which I think you all, as far as metrics folks, will really resonate. So this is a little bit of the history in measurement. And so for many of us who want to kind of geek out on measurement here. So 2009 CHIPRA, the Children's Health Insurance Program Reauthorization Act. So some of us who've been around a bit, and when I was in the federally qualified health center days, the CHIPRA Demonstration Act, basically they were testing measurement. They were also testing it within federally qualified health center. So we were all basically doing some testing of measurement. Basically in that time, there were 10 grants, and Oregon was also one of those demonstration sites testing out child core measures. So in 2010 was with the Affordable Care Act was also the first time a voluntary core set was introduced. So in 2010, 26 measures for adults were introduced with the Affordable Care Act. So that was voluntary reporting. There were at that time 5 behavioral health, and behavioral health loosely in my world, loosely defined. So when I was in the FQHC in those times as well, we were kind of some of those demonstration pilot sites. So in those days, we were really testing, and it was really voluntary, and they were really your diabetes, a lot of chronic disease management, and a lot of those screening. So, and a lot of integration, like, let me plonk a primary care and a behavioral health clinic and vice versa. So a lot of that was in the voluntary set. Then what we call the mega rules, or the updated, refreshed, the managed care rules came out in 2016. That's also where they introduced the concept of, hey, everybody, states and otherwise known, y'all are gonna have to report on a core set, like mandatory. So the rule came out saying, thou shalt go do mandatory reporting. And that's going to be in 2024. So get your systems ready. Rule is there. There will be a mandatory reporting. It's qualified rating system as well, so QRS, and get ready. And that is the 2024 CMS core set known as the Mandatory Adult Child and Core. So the mega rules in 2016 was really getting us on notice for what's coming in 2024. All of those blue text with the underliner, all the hyperlinks to this information. So if you've got the slide deck, click the links and have fun in reading the federal rules around behind it. Next slide. Now, one way we do take this federal background in Oregon is obviously through Medicaid. So that's what we do. That's one way we do it. So my job is not just Medicaid, by the way. So if y'all want to talk beyond Medicaid, let me know, but we are here to talk Medicaid. So let's go to the next slide. Oregon Medicaid landscape. So by the numbers, we have 1.48 as of March 7th, 2023. We have 16 Medicaid plans, 1 fee-for-service, otherwise known as open card, 8 innovator agents. And then we have what I call the alphabet soup. We have an 1115 waiver. We have a substance use disorder waiver. We have a state plan amendment, otherwise known as a SPA. We have the HERC, the Health Evidence Review Commission prioritized list. This is all how we manage care. It's how we operationalize managed care. These are words that sometimes people don't know, so I just like to ground us before we get into the managed care landscape. Let's go next slide. Okay, this is the accountability. So how we get into the performance measures, we need to know kind of some of the accountability that OHA, which ultimately rolls down to the the plans, which ultimately rolls down to the performance measures, which ultimately rolls down to the providers, which is what we're trying to do to improve the care and access to members. So the left side is the 2017 to 2022 waiver. The right side is the recently approved September 28, 2022, 2027 waiver. Left side is what we're currently operating under for our Medicaid quality strategy. State quality measures. There's an annual assessment, otherwise known as the state plan measures. There's about 33 of them. And there's an asterisk because some of those, you know, we also have the incentive measures, which you all know about because that's your privy. But we also have the incentive measures plus the state plan measures, which mirror those adult and child core set measures. Those were approved with our previous waiver. Those again are to ensure quality and access to care for Medicaid beneficiaries. There's no additional money for the state plan measures. The recently approved 2022 to 2027 waiver again got approved for the standard terms and conditions, another alphabet soup, STCs, on September 28th. The standard terms and conditions, STCs, were approved the 28th. But what's yet to be determined, as in still negotiate with CMS, as in still to be developed, is the evaluation plan, the monitoring plan, the Oregon's Medicaid quality strategy, which I'm going to be talking about here in a few more slides, and the measurement to assess quality. So you can see there's still some pretty substantive bullets and plans to be developed with CMS as we are still working with CMS on each one of these, which relate to a whole lot of things of measurement, which is what you're having me talk about. Next slide. So why does a quality strategy exist? Well, to provide a roadmap and direction for OHA, CCOs, and health systems to improve care and access. And technically, yes, it's federally required for managed care plans and states to have. So obviously, you need to have one because there's an actual federal rule. But why you need to have one is because we need to kind of know what we're doing and where we're going. So you do it because it's required, but we actually do it because we're trying to have a roadmap of where we're going. Next slide. So here's a snapshot of the updates to the Medicaid quality strategy. So I'm going to actually walk through this one here a bit because it's really the key information that you should know related to the quality strategy for Oregon's quality strategy. In May of 2021, we refreshed the updates to the Medicaid quality strategy to align it to Oregon Health Authority's 10-year goal, which you all know about. Also aligned it to the health equity definition. We aligned it also to the CCO 2.0 priorities, what was to bring it up to the CCO's current contracts. We aligned it to the State Health Improvement Plan, otherwise known as Healthier Oregon. We also aligned it to the current federal regulations known as the CFRs. We also aligned it to the quality payment programs. So that was quote unquote the more substantive update. Then last September, we also aligned it to something known as the Qualified Direct Payment Goals and Objectives and Measures. That's the preview I'm going to give you here in the next few slides. Next slide. This is a visual to kind of walk you through how it all comes together. I don't have a laser printer or a laser pointer, so I'm going to walk you through left to right. So left bar with the yellow star is the OHA strategic goal. Follow the flow diagram from the yellow star to the green box Medicaid quality strategy. That's the OHA Medicaid quality strategy. That's not the CCO or the practice. Now, the CCO and the practice might have their own, but the state one. Now, what you have is the purple box. That's long-term services, otherwise known as skilled nursing facilities. They have their own. OHA carves out long-term services, and our partners over at DHS, Department of Health Services, Human Services, they have their own quality strategy, but we should partner with them. So there's, you know, a dotted line over there, and that's connected to its own little waiver, their 1915 waiver. So I noted that, right? But we should have awareness, especially for our dual eligible partners or members, which are people who have Medicare and Medicaid. So that's why it's on the visual. If you see the green box, let's stick in the green box. That's your guys' scope. This is your individual scope. Medicaid quality strategy should have some goals and objectives. We should know what we're aiming to do for our members. You should have some measures. We should have measures. That's the green box that says measures. Within that, you see a CMS, Adult and Child Cord Select, and Oregon Upstream. Below that, you see something called the SPA in the yellow pentagon. That's the state plan amendment. That's how we run Medicaid in bulk, the operational details. The other pentagons are the waivers. The red one is the 1115 and the SUD waiver, the substance use disorder. The other turquoise, bluish box is qualified direct payment. That's another way in which a lever that we hand out different funds or financial incentives. That's another way at which you're administrating Medicaid. Those might have different goals specifically for those levers. Just like waiver, we're trying to test out continuous enrollment. We're trying to look at how we do transitional housing. We're trying to look at how we're testing out transition from correction into the system, right? Those are the things that are transformational in the 1115 waiver, which you all know about. Those will have specific goals, and they might have specific evaluation measures, but they also might be connected to the overarching green box of waivers. That's why there's dotted lines. And they can be one and the same, or they might have separate measures. That's basically the connection points. I'm going to move on from that, and we can ask questions if we need to later on. Now, Oregon's Medicaid quality strategy has key requirements. These are directed from CMS. They're recommended but not required. The message here is recommended, not required, but probably will be required. That's the message. It needs to include goals and objectives, and it needs to include measurement towards those goals and objectives. It needs to include a health disparities plan. Has to be updated no less than every 3 years. It needs to be posted for public comment and publicly posted upon completion. So that means it needs to be posted for public comment, and then once it's complete, it needs to live up on a public website. That's the distinction between those last two. Next slide. Now, these here are the CCO quality elements. So what this slide is to depict is basically CCO incentive measures are one lever of quality. It's not the only lever. There are many. So you can see there are several items CCOs do in the quality realm. The Healthier Oregon, the State Health Improvement Plan, is at what I call the macro view of population health. It's across Medicaid population. It's across populations. Medicaid. It's across the whole Oregon. It's everyone. So it's across payers, payer agnostic. Let's put it that way. Community health improvement plans are payer agnostic as well, but more regional. So it's regional based, still payer agnostic. Transformation quality strategies are Medicaid specific, so Medicaid population, and they're still they're project based still, but they're probably like what I call the 100,000 foot level. So the projects they can last over a period of time. So that's the easiest way of putting it. Performance improvement projects are project based, but they could be more rapid cycle. And then you have your incentive measures, which could run the gamut of any of those between PIPs and transformational quality strategy. Across all of that, there's a measurement strategy. There's measurements from the top, state health improvement plan, all the way down to incentive measures. There's measures across everything. That's all built on your quality program and foundation, meaning compliance, quality assurance, quality improvement. Next slide. Updating Oregon's Medicaid quality strategy. So let me just get into the pieces of where the Medicaid quality strategy is going. And if someone wouldn't mind doing a time check for me in the chat box, that would be great. Next slide. So here's where the quality strategy, this is literally just a snapshot. This is a snapshot of the actual quality strategy, the actual table of contents. The hyperlink on the 2022 version takes you directly to Oregon's current iteration of the quality strategy. So if you click the 2022 thing, it will go to Oregon's current version that's up on the web. Next slide, please. Here is an example of the actual, thank you for the time check. Here's the example of the actual goals. So what you'll see is the format has been updated to reflect CMS's guidance. So on the right, if you look just at the picture, you have a goal, you have an objective, and you have a measure. Goal, objective, measure. This is where CMS wants us to go. Goal, objective, measure. This has been formatted to reflect the Qualified Direct Payment Program. This reflects, if you open the actual whole document, it reflects only the Qualified Direct Payment Program measures. It does not reflect the CCO incentive measures. It does not reflect the state plan measures. And there's a paragraph above this that says this does not reflect all of Oregon's state plan measures or all their measures. The reason it does not reflect that is because I did not convene the whole group of every public engagement to reassign everything under different goals. The reason we did not do that is we were waiting for the waiver to be adopted and go through more of a public engagement process to align that. We did go through a public engagement process around qualified direct payment, and that's why. Next slide. The goals themselves have been aligned to the state health improvement plan, the Healthier Oregon, and aligned towards the waiver. So these are the current goals as they are prior to the 2022 waiver being quote, approved. So we have ensure quality and access through equity, access to equitable preventive health care, improve integration and care coordination, ensuring a skilled and educated healthcare workforce, and culturally competency approach. Next slide. Metrics and scoring linkages. So this is where you all come in. So having to select incentive measures, but bringing in the heart and equity side to it. So kind of where we're going with incentive measures. Next slide. This is the start of a logic model driver, and so I'm not even going to go into all of the drivers, but you can see part of the driver to get us to our eliminated health inequities by 2030 is performance measurement. And within that performance measurement driver, down at the orangey boxes is the CMS core measure set and the upstream measures. You can see in there's quality forms of qualitative and quantitative measurement and partnerships. And so I'm going to kind of bring us into that zone of conversation, and metrics and scoring is part of that conversation, and how we bring in partnerships, how we're bringing in community, how we're trying to transform that dialogue, how we change that power distribution. That's really that exact conversation that we need to have. So how we get there, that's to be determined. Next slide. Here's what's to come. So as you can see, I've just talked about a little bit about the CMS toolkit. The 2022 waiver, we're there, 2022, right? That just got approved. 2023, well, we are in that approval. We're still waiting, honestly, for qualified direct payment updates. So I have to refine it every year with the qualified direct payment. We need to work through that alignment with that 1915 with our long-term services. We need to look for that alignment with the Health Equity Quality Metrics Committee, asterisk, working through legislation. So I need to work through the post 1115 waiver approval with those mini documents that I said, the monitoring plan, the evaluation plan, the measurement strategy that's going to be in the quality strategy. So those are all based upon, you know, a timeline with CMS as well. So that's kind of where we're in that 23 zone right now. Next slide. These are the many partners who will be involved within that quality strategy development, and where and how you get plugged in. So the conversations where I regularly have quality strategy meetings, the Health Equity Committee, the Medicaid Advisory Committee, and the Quality Health Outcomes Committee. So that's mainly it's the Medicaid Advisory Committee, as well as the Quality Health Outcomes Committee, otherwise known as QHOC, because it's the quality strategy and it's QHOC, so quality, there you go. So that's held on the second Monday. I'm more than happy to come back here to give whatever updates as you all see fit, but those are the two primary points of connection. And then we'll continue to work it through the waiver work stream in regards to the other community engagement through these partners. Next slide. And we are to questions. Hopefully the timing worked out.
It did. Great. Thank you so much, Lisa. Amongst us thinkers, thinking caps and ideometers here, who has any questions or comments for Lisa? That's a great slide.
And we can go back to any of the slides that had kind of those visuals that I was kind of tying it together, if you'd like.
Go ahead, Manu.
Great, thank you. So first off, Lisa, thank you for kind of constructing everything. And I've heard you speak on many different occasions, and you know, you're always very thoughtful and approachable with your content. The question that I have, and so just a little bit background about me, is that I used to serve as a Medicaid dentist. And so of course, with that, oral health kind of comes to me more top of mind. And so it is, I am aware that the CMS measures do not include oral health measures. And I was wondering if you could share what is your, you know, I'm sure because as you've probably reflected on this for some time now, what is your thoughts and ideas and vision in terms of how do we really look at integrating oral health, particularly from a measures perspective into 2024 and beyond, and how should that be integrated into conversations within the health equity, you know, this new health equity metrics and scoring committee moving forward?
Manu, I was actually, I don't know if you had a chance to join or not, but on Wednesday when the chief oral health officer was here in Oregon, I was able to join in person. So I brought up the lack of adult oral health measures on the adult core set. Why not, right? Why not just shout it out while I'm in person? So I brought that up on behalf of Oregon and all dentists. And I also brought up the conversation around integration, to your point. And she was very receptive to that conversation, just so you know, Manu. And we talked about it from a chronic disease management point of view, namely back in the day when we were in the SQ8C and we were talking about how at adult we were addressing it from the diabetes management And you can't affect, well, she was actually saying it. We can't affect diabetes without looking at, the inflammation in the mouth, right? I mean, those were her words, not mine. And not that she had the easy answer saying, oh, you're going to see that measure on the core set soon, Lisa. But that was part of the advocacy that I was trying to do. And so that's where I was also coming from. Now, I don't have the magic wand of trying to get the adult core set changed, but every month in the quality technical advisory group that I sit on for CMS, I say the same thing, Manu. I said at some point they're going to probably just yell at me. But I think for me, for oral health integration, and I do this at the QHOC with our chair, we continue to try and elevate it with that in mind. It really is, how do we align oral health with where the system is at, right? So it's not an either or. It's where, because from a workforce perspective, it should be an and. So for me, and that's where I've regularly done it. So the kids, and this is what it used to be in my integrated clinic, they'd say, hi, Mrs. Bowie. And I'd be like, why are you going over there to oral health clinic and not going down there and get your immunizations? Like Mrs. Bowie is going to walk you right down to the primary care clinic and get you signed up for immunizations now, because I don't know why they'd go get their teeth cleaned over getting their shots. So I honestly just walk them down. So for me, Manu, that's where it's at, is I try and do it in the integrated approach versus an either or. So that's, I guess, that's where my thinking's at, because that to me is how we're going to try and get oral health elevated.
Okay, so thank you for sharing that response. And then, of course, your stewardship with Dr. Chalmers, and I attended that virtually. Sorry about that. I have an Apple computer, and so I have an Apple phone, and then when I get a call, like everything just shuts down on VMware. So sorry if you heard ringing in the background. So again, thank you for your advocacy and stewardship with ushering in an oral health integrative piece. And I think it's important for all of the members of the committee to have heard that as well as we step through the next few years here, with kind of keeping oral health more integrated, not only from an FQHC perspective, but then also from a all Medicaid provider perspective as we really look at driving the future.
There's good news though, that CMS does have a child core measures, and they have 3, so that's good. And again, you don't have to be an integrated practice to do care coordination. Let me be straight. You don't have to be an FQHC to do the care coordination. Like, yes, I was able to walk that kid down to get that. You can still do, rosters and say, hey, this child needs to go to these practices. So you can still do it, from a rostery case management. There's ways to do it without being in the same building. And I've done it both ways. So let me be clear, you don't have to be in the same building to do this. And I'll continue to work with CCOs in that manner.
Great, thank you. And then I did want to call out something kind of interesting, just because we talked about diabetes and adults. We have a few capital practices that have been supporting what I call reverse integration. And so we've actually been performing HbA1c testing within the dental office and then communicating back to the physical health providers or even behavioral health providers or community-based organizations to really look at driving down the HbA1c measured values. And we have had a lot of success in those communities. Thank you.
That's so cool. And we saw some really cool, we had some really, we just had a great presentation about behavioral health and oral health at QHOC. So there is some great work happening in some of the CCOs in regards to oral health that's even just absent of the chronic disease. So yes, I hear you in that space.
Go ahead, Gladys.
Thank you, Manu, for bringing that up. And thank you, Lisa, for your presentation. Something I did want to mention around just dental alone is how do we, moving forward, how do we view this as a systems approach of integrated care, a collectivism as opposed to an individualism or a silos of departments? Dental is a great example. Dental affects diabetes. If you don't, brush your teeth, floss, all that, that's going to have an impact on your diabetes. If you're pregnant and you don't go to the dentist, that's going to have an impact on, pregnancy. For children, a fluoride varnish, just because you're in the medical office doesn't mean that your doctor or the MA can't apply that fluoride varnish while they're there in clinic. Manu, the example around hemoglobin A1Cs at the dental bedside, like how do we think in that way of shifting these systems as opposed to, no, you need to go to your doctor to receive that, or no, you need to go here. Diabetes and behavioral health, if you don't understand what diabetes is, if you don't understand how stress has an impact on your diabetes, all of that. So how do we shift that thinking? Because it's all integrated and it all matters. The second comment that I had is looking at 2 slides back, you break it down between the drivers, primary drivers, outcomes, and strategic goals. In our section, quality forms of measurement with community at the center to eliminate health disparities, I did have the opportunity to tune into last month's call, and I heard 2 comments that really resonated. I think it was Courtney and Andrea around how do we create these sort of action plans with our CCOs, with the CAPs, the CACs, to think about this work differently, because as I mentioned earlier, a lot of our CAC members are consumer members, are direct community members that have that understanding and awareness. And I recall when we were setting the measures last year that Stephanie, you had asked for community health improvement plans so that could help our decision-making. How do we do more of that early on to say, hey, we're having these conversations, CACs, CAPs, let's get together. How do we create this systemic transformational change that's going to lead to healthier outcomes overall for all Oregonians? And I think for us, it's really challenging to have these conversations or to be uncomfortable in having some of these conversations, because if we truly want to create systemic change overall and transformational change, it really is going to take all efforts and all partners to really help us get there.
Well, Gladys, that's a lot there. I'll take the first part, not the second part yet, but I got an answer for the first one. So, I think about it, I'm going to respond from when, again, even though when I was in the FQHC, it's not that it can be achieved in non-integrated clinics, because prior to my FQHC days, I was in a OHSU, Oregon Health and Science University, working in a specialized clinic. So again, you can be in a small clinic within a big institution and still, feel like a small clinic in a just a private practice, right? And you have to, it's really, to me, a fairly, it seems simple, but it's not. But when you approach it from the patient, literally, and they just said this at IHI's conference in December, when you approach it purely from the member or patient's point of view 100% of the time, which is what I try and do. And so, and this is that lived and learned experience, right? Which is why we're trying to diversify committee, right? The committees, lived and learned experience. So a little bit about me. My family has IDD and so I literally, because it's like literally every day of my life, is because I'm literally living it every day from a lived and learned experience of an IDD individual. I'm like, oh, if my brother can't navigate the system, then guess what? That is it. because when you are approaching it from an IDD individual's brain, then you are pretty much trying to navigate it like them, right? And so I'm like, hey, if he can't, well, he's scared to go get his diabetes checked because he doesn't understand what the needle is. Like he doesn't even want to get the blood drawn because of this. So when you think about it in terms of that, well, I can go just because I built it. Like I put a primary care person in the behavioral health clinic. I'm going back to like 2010, 12. I'm like, it doesn't matter that I put a primary care person in the behavioral health clinic to do quote integration for chronic disease management, because none of those individuals wanted to go get their blood checked because they literally were like, I'm scared of needles. I don't know what that means. X, Y, and Z. Just because Lisa built it for integration, it didn't happen because I had to deal with the mental health barrier of what does diabetes mean? What does that needle mean? What does this, that, and the other mean? So that we had to work through all that parts of behavioral health integration first. So then we had to, when I reframed it and said, okay, let me put the member, the IDD mental health person at the center of it. And I asked the members, literally the patients in the waiting room, I just sat there with them, people like my brother. And I said, why are you not going to my person? They said, Lisa, I don't know what that needle, I don't know what you're going to do with it. And they literally just spouted off all this stuff to me. And I was like, okay, let's do peer navigation now. I don't need a nurse practitioner in this clinic. I need a peer navigator because this obviously isn't working. And I adjusted, right? And I reframed. And then we looked at integration in our particular clinic differently. So to me, Gladys, that's the response, is when we 100% lead with community, when we lead with the member, in whether that's mental health, IDD, whatever it be, as the primary source of how we design policy, how we design process, that's it seems simple, but it isn't. But that's to me.
Thank you for that. I think you're making a great point. The patient experience should always be at the center, which really drives all the efforts that we as a whole do. So thanks for that.
And it's hard, but it's not, I mean, it's hard. I mean, it is hard, but you don't know until you test it and fail, right? So, you know, I literally sat a primary care person there and I was like, well, she's sitting there by herself for however long. And then it wasn't until we sat there and asked the patient, why aren't you going? And then we adjusted. But it's really, whether it's policy, process, whatever, that's the answer. Courtney?
Hi, Lisa. Thanks for sharing all of this wonderful information with us. I just wanted to mention, I also really appreciate the driver diagram. And I like how you outlined the different CCO quality elements, which I think is, again, kind of going back to the comment I made earlier in the meeting, just really important for us as a committee to keep in mind when we're making some of these decisions around incentive measures and performance measurement related to incorporating health equity, and keeping in mind that there are a ton of other strategies out there and community assessments that we could glean information from. So I think bringing some of that information to this committee to continue to just kind of have eyes on what's out there so that we can make sure that we're not making these decisions and in silo. So, and I think one thing, you know, obviously I have been intertwined with the TQS over the past few months, and that is a huge addition to the TQS requirements for CCOs this year, was to incorporate real D data stratification for all projects that the CCOs are implementing and identifying disparities to focus on. So I think that's really important for the committee to be aware of, just that work is happening. And of course, it would be amazing to report some of those outcomes to the committee as well.
100%. And I think that application, like we said in the Real D webinar, it has to happen in practical chunks or what is realistic. And people have heard me say that, you know, we have to be able to create systems that are realistic so that we don't break a system as well. But we do have to move. We have to move because the members need us to move. So not moving and not acting is not an option, but we do have to make it realistic and move. So, Jorge?
I want to join my colleagues in thanking you for your leadership and stewardship of our quality strategy and your excellent presentation, Lisa. Thank you for your excellent work and over the years. And this important follow-ups on oral healthcare, integrated care, aligning the patient perspective when we need to take care of whole populations, and aligning the hard work of community engaged plans and initiatives that already exist are very critical. So thank you very much, Lisa, for being with us. Really appreciate it.
Thank you, Jorge.
Other thoughts or questions for Lisa? Okay, well, thank you again so much, Lisa. This is really helpful to kind of get this overview, and we're probably going to take some of your visuals and just kind of put it within our monthly meeting slide decks, so we can always have something to kind of refer back to just kind of, you know, sometimes we have to be reminded, kind of set the stage of what the overall goals are, where our place is in terms of these overall efforts that are happening across OHA. So thank you, and across the state. Thank you.
Of course.
Yeah. So I'd like to take the remaining time for us to kind of really digest not certainly the information that we've heard today, but the information that we've heard since January. We've had a number of different presentations, one in January about the Real D repository and the progress with that, as well as last month we talked about the Real D and disaggregation of the data, as well as the dashboard. And then today we talked about the working paper and what other states are doing to incentivize health equity. And so kind of similar to the question that I asked last month in terms of kind of how do we take this information and use it to guide our work, at least for this year and certainly for next year, as well in terms of us informing how we do benchmarks. I think last month it sounded like we were in agreement that we're not quite at a place for the 2024 measure set to start really setting kind of health equity benchmarks. But certainly I think we are in a place in terms of thinking about what do we need and what potentially is a framework that hopefully we can set a foundation for the Health Equity Quality Metric Committee to kind of take and then keep going with that as they plan to do and move forward. So I just jotted down a couple of notes as I was listening to Lisa and reflecting on the other presentations. And then would certainly like to hear other people's thoughts in terms of additional things, in terms of kind of what do we need? How do we start to really move this work forward in terms of health equity benchmarking? And so I think it was something that Gladys said that stuck out to me in terms of, you know, we're talking about the community health needs assessments, but what is the process, or what is the way in which communities are going to be engaged? How are we going to seek community input to then inform the benchmarks? You know, is that community health needs assessment? Is that doing focus groups? Is that having people encouraging more public testimony during the actual meeting? So having some sort of a framework and process for how exactly do we how do we meaningfully and respectfully engage the community? Another thought, just going off of the working paper, you know, and this is going to sound silly when I say it out loud, but hopefully you guys get what I mean. How do we define disparities? And what I mean by that is, what's the reference group? Who are we comparing to who? And what is the amount of difference where we say, okay, this is a disparity and we need to do something about it? Is that a statistically significant difference? Is it a clinically significant difference? Again, do we engage the community to tell us like, well, you might have these numbers, but this is what I'm living. This is what I'm experiencing when I go in and when I'm in my community day to day. So really thinking about that as well. And then lastly, what's the level of completeness do we need for the real D data? So I've heard Manu, talk about starting with the disability data. There's a lot, seems like there's a lot of work still to do in that space, but even a race ethnicity space, I could tell you from Kaiser, we got to do some work on even just asking people, there's still a lot of assumptions of like, well, you look like this, so I'm going to put Black. No, how do we start to train and make sure across the board, people are being asked the question, and how do we complete that data? And what's the workflow and all the electronic stuff that has to happen with OHA to start making sure that we have more complete data for all of those domains. So those are just a few things that came to mind for me, but we'd love to hear from the rest of the committee members. Go ahead, Jorge.
A number of us have participated, worked, planned, executed community health plans and health equity plans. And those require a lot of work and significant amount of community engagement. So I think that there is a glide path there of how to leverage that ongoing hard work that, to my knowledge, it's been around since the inception of our current modern CCO system. And that includes not only reviewing that information, but we could also take into account conducting gap analysis. So what is the information that is clear and what is information missing, so that any new data collection is and community input is focused on gaps. And also going back to the beginning, the membership in these committees of the members of the community at large, bringing in individuals that have that significant expertise, experience in participating in these efforts, I think would be a good strategy.
Thank you, Jorge. Gladys, I think it was a quick draw. So
Thank you. Stephanie, I echo your sentiment around how do we ensure that folks understand how to address or ask the questions in order to really inform and give better data overall. And I recognize that that will take time, but at least there's a start, right? We have something versus absolutely nothing. The only other piece that I guess I would add right now and strongly encouraging us to do so is how do we have, instead of reinventing the wheel and starting from scratch, how do we leverage our CAC groups, our CAPS, CPOP teams, because they're already connected to the community members. And that's something that we could start now. If we have a draft set of goals that we want to set or release and give folks time to think on it. Hey, how is this going to work well here? How's this going to work well here? What's not going to work well? And then they are bringing that information back to us so that when we are ready to make a decision, at least we've had input from those select or specific CCOs. What's worked well in one CCO could potentially work well in another. So that that idea sharing on what processes were built to achieve this QIM, I think that would be really helpful, at least for me, to be able to set a measure alongside you all around dental or whatever it may be. We've had input from multiple groups that are connected directly to the community that can help give us that information out now, as I do recognize that we are on a timeline.
Thanks, Gladys. Courtney?
Thanks, Gladys. That was actually almost exactly what I was going to say. I was going to reference the article that Allison sent with the meeting materials, the Tuck article. And I feel like that's something that's kind of was eye-opening for me, to think about the fact that, you know, doing all of this community engagement and singling out groups of individuals is not always the best way to approach this. And so I think, to Gladys's point and to Jorge, that leveraging a lot of the work that has already been done within these communities would be extremely beneficial to not, you know, re-trigger or re-traumatize any of these individuals. And so I think that would be a really good place to start. I also know that, not to put Sarah or anyone from OHA on the spot, but I know that they've been trying to think of good ways to engage the community as well in some of the benchmarking and measure settings. So I don't know if they plan to maybe bring some thoughts or review that they've done to us as a committee in the future, but I would definitely be open to hearing their thoughts as well.
Sarah, do you want to comment? You're still muted if you are commenting.
Sorry, I got muted on. Yes, I can chat now. Yeah, we've definitely been thinking about it, and it's Gladys and I actually had a one-to-one yesterday, and we're kind of talking about this. And there's things that we can do now, right? Which is like, you know, you come up with your draft set, we can send that out to CPOP, which is the Oregon Health Authority's Community Partner Outreach Program, and it has lots of community partner organizations, just as an awareness piece. And we can do all of those kind of email blasts, etc. And that's, but I'm conscious, like, that's insufficient. That's not what we're talking about in terms of real community engagement. That's sort of the minimum that we can do. And I think that's the piece that we're looking at this year. And depending upon when you make your decisions about the incentive measure set, like, you could consider using your draft set and giving longer time for community organizations to review that information and provide input. I think longer term, our team is trying to do a lot of thinking about how to really build this into the process in a more formal way, and thinking about how, you know, thinking about the redesign of the program, the new committee, all to focus it on health equity. And along with that, there's also the program pieces and how we have to operate differently. So with that, there's looking at having some staff that would be able to help us to engage communities in ways that we haven't been able to before, but that would be dependent upon whether that funding becomes available. And then Dr. Marjorie Mickey and Dr. Eileen Duldelau, our partners in our Equity and Inclusion Division, have been very giving and are interested in, so they can help support us in this work. But to the point that Gladys made about time, that's where, like, that's going to take us time to build that, which I know is not, that is not a good answer. I'm conscious of that. And I just want to be really honest as well.
Thanks, Sarah.
Other comments or questions? One question that I had that kind of came up a couple of times as I was listening today, and it certainly touches upon, you know, the work that CCOs are already doing, certainly with the community, but I'm also just wondering about other initiatives that CCOs are doing and the process in terms of how those initiatives are being evaluated, and how can we kind of take that information and learn from that information as well. And so, you know, I know HealthShare was doing quite a bit in terms of traditional health workers and reimbursement and getting them integrated into health systems. And I'm sure there's a number of other CCO-led initiatives that then still feed up to this overarching goal of health equity and addressing social determinants of health. So not those individual social needs, but the actual, you know, basically the issues that we are facing that certainly distinguished, socially advantaged, and socially disadvantaged. And so just curious if there's reports that I guess CCOs put together in terms of their initiatives and the conclusions from those, and anything that we can kind of glean that can help us think through as we're setting benchmarks. Go ahead, Courtney.
Thanks. So yeah, there's a lot of really amazing things that the CCOs are doing, and most of the things are published on the OHA website. One of them I would say that is relevant to kind of what you're inquiring about is the health equity plan. And then the other is the transformation and quality strategy that each CCO has to put in place. And that's kind of what I was mentioning when Lisa was presenting, that was a newer requirement for this year for the CCOs to include real D stratification and disparity focuses within each of the components that are required within that. And there are 2 health equity specific components that CCOs have to have projects in place for, and also an SDOHE, social determinants of health and health equity component as well. And so those are actually posted online on OHA's website for everyone to be able to review the entire write-up, as well as the monitoring measures and updates. So there is monitoring that each CCO is required to do for each of those projects that they propose. I will say they are very long documents, so some fun late night reading if you would like. But I do think that paints a good picture of some of the projects that are in place across the CCOs.
Thanks, Courtney. Andrea?
I was just gonna say the same thing as Courtney. So she's captured most of it. The other document that all CCOs just submitted was our action plans for the social emotional health metric. And by nature of that metric, each CCO was to evaluate, the most kind of at-risk groups of children and identify a population that has historical inequities to really focus on over the next 3 years. So that would be another measure that, there's documentation, and I believe it's been posted or is going to be posted on, I think Sarah's saying not yet, but I think it's going to be posted on the CCO or the OHA's website. That would be another resource.
Great. Go ahead, Jorge.
This discussion of existing strategies in terms of what is the already organizational infrastructure that we have in place to prepare organizations to continuously engage, evaluate, and improve our health equity levers across the state. I think it's connected directly to the types of measures for health equity. There's at least 2 branches, right? One of the branches is measuring health equity promoting measures. And those can be focused on organizations and what systems are in place and how those continue to be strengthened to promote health equity. The other branch, of course, is the service utilization and so forth, upstream and downstream measures. So I think that there is, again, a lot of material there to be leveraged in connecting these dots in the plans that already exist as part of the quality strategy, but are not necessarily part of this portfolio that is to incentivize, unless I'm wrong about that distinction, those could be connected really well.
Go ahead, Lisa.
As far as the CCO transformation quality strategies, I am the sponsor of it and one of the OHA leads on it. I think in our CMS quality reports that we give annually, I think I have a summary across all CCOs, so that you all don't have to dig into every report. So are you looking just for the health equity components and how they're doing, or are you looking for the breadth of all quality areas? So that's what I'm trying to gauge here. Because there's like, what are there, Courtney, like 14? I should know this. There's like 13 or 14 components. Last year we had access, then we took out access. So across the TQS, there's anywhere from 13 to 16 areas of quality and transformation we're looking at. And then we assess them on a 0 to 3 scale of each component. And so there's 4 for health equity, because there's 1 related to health equity data, health equity cultural responsiveness, there's cultural class standards. So there's a bunch. And so I'm trying to figure out, do you want an assessment across all CCOs just for the health equity ones, or other areas of quality and transformation? And if so, I can dig out of the report that we gave to CMS and get that to you all, or just the health equity ones.
So as a researcher, I like to see everything, and then I can I can figure out what was actually really what I really needed to look at it out of those 100 pages. Just because I'm not as familiar. I don't work for a CCO, so I'm not as familiar with those reports and how the layout is. And so I would say, go ahead.
Then I'll get the report that we gave to CMS, which basically is a summary of the CCO's performance across all components for all CCOs. And then you all can dig into which of the CCOs you want to go, learn more about their projects. Because each one of the CCO's reports, TQS reports, are like 100 pages, right? But then you can be like, hey, I want to go look about this report, right, with this CCO. But at least it narrows it down for y'all, because you can look at any given CCO's reports within their components. So I will go get that report and get it to Sarah, who can email it out to y'all. It's somewhere on the public website somewhere, but I gotta go dig it up. And so I'll find that.
Thank you, Lisa. So in our last remaining 9 minutes, again, any other, go ahead, Jorge.
Yes, I do want to pay attention and be responsive to the what you post, Stephanie, in terms of we do have a big topic in terms of deciding the standardization of measuring health inequities or disparities. And we were informed today about a variety of illustrative case examples that are being used. And I think it requires that we really take a very close look and examine what are the basically advantages and disadvantages of the different methods per se, and then of course the readiness that we have with our existing infrastructure in our state. I just wanted to say that probably really requires a deeper look examination, and that hope we can continue to engage in that in a meaningful way as we look forward to the next 2 years.
Yeah, agreed, Jorge. Can I, Sarah, I just saw your hand pop up. I have just quickly, I'm wondering though, and this may not be this year, maybe it could be done next year. I'm wondering if OHA can take some existing data and play around with it, because I don't want to play around with actual people's lives. But if we have data and say, okay, what if we set an incentive for this metric, Latinos, based off of how they compare to whites, or based off of how they started before, and using kind of maybe, I don't know, 2018, 2019 data, and see, I'm literally just thinking this off the top of my head, but I'm just wondering, with all the data that is available, if there's a way to do some kind of analysis to kind of play around and see what would happen, what differences we would see, what would come up, and that would certainly help to inform, I think, our discussion a little bit more as well. Just like when we have the calculator, when we're trying to think about benchmarks and how to set it in the floor and everything like that. If there's something that we can do on the equity side of that would be helpful, if that's possible. Sarah, I can't hear you.
I don't know why.
There you are. There you are.
Something keeps muting me in Zoom. So if someone's doing that, please stop. Not me. Do you mean testing out, I guess, a couple different things? Do you mean testing out different ways of identifying the disparity as well as potentially different reference groups?
Yes. So one, if we set white non-Hispanic as the reference group, if we set the state average as the reference group, if we set the group itself as their own reference group, what kind of shakes out of that over time?
I think related to this is what I raised my hands about. I think we will be looking at some of these pieces. So our team is having regular meetings with Dr. Doldalau, who presented to you all last month, and talking exactly about these pieces for you to make these decisions in the future. And Dr. Doldalau is in our equity and inclusion division. And so on our side, we would look to them for guidance about, what different methods might be used or the appropriateness of different methods, and look to bring that information to you all over the course of this next year. And
okay.
I'm sure this even beyond, I'm sure it'll be an ongoing conversation.
Yeah. Okay. Thank you. Did you have anything else, Sarah? Was that it?
That was it.
Okay. Okay. We're in our last 5 minutes. Any other burning thoughts or questions? Okay, so when we meet next month, I believe we're going to be talking about the CMS core set, as well as hearing some recommendations from OHA. Before we start getting into that, that timeline again of like decided on metrics and decided on benchmarks. So, but still, I don't want to lose this important discussion we've been having. I certainly want that to inform our discussions in our work as we move forward with benchmark setting. Certainly, I think the way that the meetings are set up, there's still going to be time enough to discuss and to process. And I agree with you, Jorge, in terms of like, even to still keep talking about how are we defining and looking at disparities, and what is our kind of a definition and ways of analyzing data in that way as well. So certainly don't want to lose all of the progress that we've made and the important discussions that we've made since January. Okay. So with that said, everyone, please enjoy your Friday evenings and your weekends, and I will see you all next month.
Bye all. Thank you for your time.
Thank you. Bye, everyone.